So how does one approach sleep symptoms? So once a patient lands in the lap of the sleep physician, so to say, a sleep story or the sleep history has to be taken. So what does one have to ask in the sleep history? Sleep hygiene, which I'll come to in a moment. Sleep, which was a subconscious process where people would gradually wind down and go to sleep, has now been reduced to one more chore in the daily event. So sleep also has to be ticked off your list. So it is important to relearn sleep hygiene, just like how we are relearning how to eat, what to eat, and stuff like that. Sleep quality and duration also has to be asked about. A history of comorbid illness, drug usage, and shift work, all of which can affect sleep. And once there are issues around this, a sleep physician evaluates whether the patient is sleepy, and even if they are not sleepy, are they able to respond appropriately to situations requiring alertness. And once these screens or filters have been applied, we can decide whether objective evaluation is required. Obviously, examination, some anthropometry, especially for sleep disorder breathing, upper airway assessment and a systemic exam is in order. And then one needs to decide, after all of these are checked off, whether we really need to bring the patient into a sleep lab and work up for a sleep disorder. So I'll take you through this story in the next half an hour. So the beginning. It's very important to know the background of the patient when they come with sleep complaints, the education, occupational status, dependents at home, work schedules, and shift work, because all of these can affect sleep and we should not be wrongly making a diagnosis of sleep disorder. One example would be somebody who is studying for a qualifying exam may have sleep deficit and so may complain of sleepiness. So we cannot really talk about a sleep disorder unless we have ruled out that we are sleeping properly. Occupation is another thing. Certain critical occupations cannot afford to sleep or doze off at the workplace. For instance, drivers, pilots, air traffic controllers, doctors cannot afford to even have a minute or a second of shut-eye during work. Also, these professions work in shifts. So shifts also can disrupt sleep hygiene because, like I told you, nature designed sleep to happen in darkness and for us to be active during daytime. That's hardly happening now because of the 24/7 schedule. Dependence at home, especially a small child or a sick elderly or a sick spouse, can also disrupt sleep. And like I said earlier, shift work can disrupt sleep. So in the context of the general background of the patient, when they complain of those three complaints which I talked about, insomnia, inadequate sleep or habit, certain events happening during sleep, we have to ask about sleep hygiene. So this essentially encompasses when the patient goes to bed, how long they take to go fall asleep. Do they wake up in the middle of the night? What is their wake up time? Is the sleep duration enough? And then what happens during sleep, if they can remember it. What is also important are the events happening around sleep time. You will agree with me that most of us switch off our gadgets and then close our eyes. So most of the times we are exposed to blue light or white light before going to sleep. Most of us rush off to bed after a heavy dinner. All this is not in the interest of sleep hygiene, which I'll talk about a little later. Once you have established their background, sleep habits and hygiene, we ask for sleep-related symptoms, which can be nocturnal. This is best recounted by a bed partner most of the times. The patient also may complain if they have disorders like restless legs. They might say that I have pains or I have uncanny sensations in my limbs preventing me from sleeping. Or sometimes a snorer snores so loudly that they get woken up by their own snoring. And of course, daytime symptoms are consequences of disrupted or inadequate night sleep. So these are the things we need to ask in a patient with sleep complaints. Like I said earlier, history from a bed partner, a parent, or a roommate is also important in arriving at a diagnosis of a sleep disorder. Now, coming to sleep habits and hygiene, like I told you earlier, all these have to be asked: bedtime, wake up time, on weekends and holidays. Winding down rituals. This is very common, especially in the 24/7 lifestyle. You drink a lot of coffee, tea, colas around bedtime. Ideally, it is said that 6 to 8 hours before the proposed bedtime, you should not take any form of caffeinated drink. You might fall asleep out of tiredness, but the sleep architecture gets disrupted. Meal timing is very important, and there is a new field of chronobiology or chrononutrition which is coming up, which really addresses nutritional problems among shift workers, where meal timing and composition have a big effect on causing problems related to shift work as well as shift work related disorder. Timing of exercise is very important. One cannot do weights just before going to bed, but early evening exercise is known to promote sleep. And like I said, gadget or light exposure. I'm sure most of us can relate to the third cartoon where we are checking social media and we have dropped our phones on our face. So this is a complete no-no for good sleep. So staying awake a long time, a lot of coffee, look at this bunch of bears. Coffee in June is preventing hibernation in winter. It's not as bad for us, but coffee in the late evening can disrupt sleep. So these are important things we need to ask the patient, and correcting some of these may actually reduce the sleep-related complaints and obviate the need for workup in a sleep clinic. Now, how do you analyze sleep symptoms? Now, we have taken a history. We have figured out the background sleep habits of the patient. How do we analyze these symptoms? Let's go one by one. Insomnia can present as difficulty in falling asleep, difficulty in staying asleep, or frequent nocturnal awakenings, and inability to go back to sleep. There are patients who have told me I haven't slept for 40 years. That definitely requires a sleep study, because there is this component of psychophysiological insomnia where the patient is actually falling asleep, but they think they're awake, but that comes in the end. Insomnia can be acute. Any of us who has gone through a stressful period or has had to make a decision with respect to career or otherwise would have experienced this. Insomnia can be transient. That means it's there for a few weeks and then the stressor goes away and the acute phase of insomnia passes. It can be chronic when, like I told you, 40 years I haven't slept at all will be the history. So there are 3 stages of insomnia: onset, middle, and late. Onset insomnia is when somebody hits the bed and can't go back to sleep at all. Middle is when they wake up and can't go back to sleep. Late is when they wake up a little before the scheduled wake-up time. Everyone else is sleeping. They can't sleep and they can't disturb others, so it's very distressing. They might have had their quota of sleep, but this is 4:50 a.m. may be okay with many of us, but not in many households. So these are the 3 stages of insomnia. So this is something we should ask somebody with insomnia. How do we approach? This is a rather crowded slide which I have adapted from Krieger's Principles and Practice of Sleep Medicine. Very broadly, what can cause insomnia is if there is a circadian rhythm disturbance. So in this context, all of us should know that we have our own intrinsic clock and we also have our own propensity to be owls or larks, so to say. Some of us work best at night, some of us work best when we wake up in the morning, and some of us are very polarized. For instance, can't follow anything, can't wake up in the morning at all, can't go to school, there are people or work, there are people like that, extreme owls, and people who can wake up very early in the morning and work. Most of us are somewhere in between. We are able to conform to social norms. So any circadian rhythm intrinsic disturbance, like the patient's morningness or eveningness, or particular sleep disorders like advanced sleep phase, delayed sleep phase, irregular type, etc., can also disrupt the circadian rhythm. In the modern era, the most important circadian rhythm disturbance occurs due to shift work, the 24/7 schedule, and people globe-trotting a lot, experiencing jet lag. Also, non-sleep-related problems like other sleep disorders or even extrinsic issues can affect sleep and cause insomnia. Could be intrinsic, I'm not going into details. Psychiatric and psychological issues can also cause insomnia. So before prescribing something for insomnia, we have to see whether the patient's circadian cycle is correlating with what the patient intrinsically is. or whether there is any underlying disorder, painful, disturbing condition which is preventing them from going to sleep. Do they have any psychiatric or psychological issues which is preventing sleep? Now, next, coming to the next symptom, unusual nocturnal symptoms. Certain things are very self-explanatory. Things like night terror, which people complain of screaming and amnesia for the event. The bed partner or the parent usually complains. People may be walking around, talking, eating, and sleep. Again, the spouse, bed partner, or the parent complains. REM parasomnia, which is a dangerous situation where a person wakes up and usually enacts a violent dream and doesn't remember. So they may be very loving spouses in the morning, but wake up in the middle of the night and try to throttle their bed partner. This could be because they are having what is called REM parasomnia. So detailed history is important. Repetitive stereotype movements indicate seizures, and among children, bedwetting is a sign of nocturnal enuresis. History from the bed partner is vital if there are unusual behaviors in sleep, and video evidence. Many times people are able to provide video evidence, and this can obviate the need for a sleep study. What we also need to remember is that with all these parasomnias, need not happen every night. So if you bring a patient into the sleep lab and that particular night nothing happens, you cannot discredit the story given by the parent or the partner. So many times video evidence is important. And for diseases like REM parasomnia, where crimes may be committed in dreams, we might have to demonstrate certain polysomnographic characteristics to prove the disorder and proudly exonerate people. There are instances in the US where a person has been exonerated of their crime after proving that they had a REM parasomnia. So how do you approach unusual symptoms? Again, it's a crowded slide. I'll quickly take you through. You have to look at non-REM related disorders, REM related disorders, other parasomnias, movement disorders, psychiatric and neurologic issues. So it is not as simple as taking a 2-minute history and forgetting about it. A little bit of detail is required, and believe me, it's very interesting to evaluate a patient with a sleep disorder. And when you reach to the bottom of it, it is really fulfilling. Now, what are the daytime symptoms in sleep disorders? Commonest is excessive daytime sleepiness. They might come with being sleepy in passive situations. I think most of us are, and I wonder how many of you are sleeping now that I'm talking about sleep early in the morning. Active situations, people may be sleepy, like driving, conversing, operating machinery, or they may have sleep attacks where they are so sleepy that they have to drop whatever they are doing, go into a room, take a short nap, and come back. That again indicates a certain sleep disorder. They may have daytime symptoms of nasal congestion, dry mouth, or morning headaches, which again indicates that they have been, the nose has been blocked, they have been breathing through the mouth and snoring, and probably this has led to the daytime symptoms. And because of poor quality sleep at night, they may come with difficult concentration, memory, and increased irritability. Frequency and duration of daytime napping may increase. Somebody who's been active all day might steal a nap during the work hours. And cataplexy is another daytime symptom where in an emotional situation, the patient feels his or her knees buckling and they have a drop attack. So this is very characteristic. Sleep attacks and cataplexy are quite characteristic of a disorder called narcolepsy. Now, how frequent is excessive daytime sleepiness? About 5 to 20% of patients with a sleep disorder can complain of sleepiness. Like I told you earlier, it can be after work or in a passive situation. Duration, pre-morbid sleep duration and sleep quality are very important. Like I told you, you have to take a detailed history to see why the patient is sleepy. It's not a disorder all the time. How do you approach excessive daytime sleepiness? Again, we look at issues like circadian rhythm disturbance. I already spoke about it. Sleep disorders. Somebody with insomnia may present with excessive daytime sleepiness. So the list almost looks the same. But very importantly, with excessive daytime sleepiness, this particular group is very important. Intrinsic sleep mechanism disorder, where there are specific diseases which produce sleepiness. And the second one, sleep disturbances due to sleep-related breathing disorders are very important. Now, what are the clues to diagnosis when somebody comes with excessive daytime sleepiness? History is very useful. Insufficient sleep can cause sleepiness. Sleep can be disrupted by pathological events, and some of the clues are sleepiness with snoring, choking, and dry mouth is sleep apnea. If they have cataplexy, daytime sleep attacks, and hallucinations could be narcolepsy. If there is a reverse daylight sleep pattern, could be a circadian rhythm disorder, provided they are not shift workers. That also may cause a reverse daylight sleep pattern. Sorry for the spelling typo here. Symptoms of mood disorders like excessive daytime sleepiness due to insomnia caused by the mood disorder. This is again very important. Somebody with excessive sleepiness, don't dub them as sleep apnea or insufficient sleep. You have to take other supporting history. So the same thing has been put as a pictographic representation here. Snoring, choking, apnea, nose block, and dry mouth is probably sleep apnea. This triad of cataplexy, sleep attacks, hypnagogic, hypnopompic, hallucinations with excessive daytime sleepiness, etc. Tetrad actually is narcolepsy. And shift work, travel, poor hygiene is a circadian rhythm disorder. And insomnia, apart from being primary, can be secondary to many of these disorders. So once we are done with analyzing the history, family history is important in certain sleep disorders like narcolepsy, OSA where there may be a family history of obesity, periodic limb movement disorder or restless leg syndrome can be genetic or familial, sorry. Nocturnal enuresis can be familial. Many of the non-REM parasomnias can also be familial, and so is insomnia. So brief family history, whether any first degree relative has similar complaints, is very important in establishing the diagnosis. Once we have arrived at the symptom list and the possible cause, we also have to look at the impact of disordered sleep on the performance of the patient, because treatment will be directed at that. Alcohol, caffeine, and illicit drug use should also be elicited, because like I have listed here, it's a big list. All of them in a nutshell can disrupt normal sleep and cause issues. Review of other systems is important. Obesity with OSA. Similarly, hypothyroidism can cause sleepiness and OSA. I have seen many patients in my practice where hypothyroidism was undiagnosed. Patients straight away went to a sleep specialist, got a CPAP prescription, and then realized later on that, oh my God, TSH is high, probably that is corrected, symptoms will come down. So we routinely do a workup for hypothyroidism, especially in patients with violent sleep apnea and excessive daytime sleepiness, so that we can correct and then impose CPAP on them. Nocturnal asthma, systemic disorders, gastroesophageal reflux, and one to be added to this list is left ventricular failure. People may get up in the middle of the night with paroxysmal nocturnal dyspnea and may experience insomnia. Also, neuromuscular chronic respiratory failure can give rise to poor sleep quality, because the ventilatory system is reset, muscles are weak, they don't sleep well. Chronic pain syndromes can cause insomnia. Psychiatric disorders can also cause. Some of these things are being repeated across slides because one needs to realize that a patient with a sleep complaint is not a sleep disorder alone. It may be secondary to a lot of things, which include environmental, social, psychological, organic diseases, and sleep disorders. That's the reason I am repeating some of these points. Many of the drugs can disrupt sleep. Sedatives and psychotropic drugs may be very sleepy. Anti-epileptics may cause sleepiness. Someone on a diuretic, doctor has prescribed to take at 4 p.m., patient is taking at 10 p.m., they're up all night going to the restroom, they may have disrupted sleep. Beta agonists can disrupt sleep, and drug abuse obviously can disrupt sleep. So once we've got a good history, we go to the examination where we again do a system review and we do a sleep disorder specific examination. Here the most important thing is to look for sleep disorder breathing. That's why anthropometry, neck circumference, orofacial and nasal abnormalities, and an upper airway assessment is important. I won't go into details. In the examination of the head and neck, we basically, again, this list was for medical students. You basically look for any facial abnormalities or mandibular abnormalities in a patient whom you are suspecting sleep apnea. You also examine the oral cavity, simple maneuver. Ask the patient to open their mouth and look at the anatomy at the back of the mouth. Look for an elongated soft palate and uvula, tonsillar enlargement, or any edema or erythema of the posterior pharynx, and enlarged tongue. So very simple maneuver, recommended to do 2 feet away considering the pandemic. Ask the patient to open their mouth, put out their tongue. If you can see all the anatomical structures clearly, it's a class 1. This is a modified Malampati, which is used in anesthesia as well for airway assessment. Class 2, you can see it's getting more and more crowded. You cannot see the pillars at all, only the soft palate and uvula are seen. Class 3, where nothing is seen, it's all looking pink, no anatomical structure. And class 4, where it's not visible at all. Somebody in the class 3 or class 4 with a history of snoring is very likely to have sleep apnea. Head and neck examination, important again for sleep disordered breathing. For most other disorders, this kind of examination is not required. As you know, there are 88 to 90 sleep disorders, and probably only sleep disordered breathing requires this much evaluation. Look at the neck circumference, and with the suggestive symptoms, you consider evaluation for sleepiness or other symptoms. So what are the types of sleepiness? Somebody says, I'm sleepy, introspective self-assessed sleepiness. The patient is reporting. Physiological, all of us are entitled to have physiological sleepiness. It's a biological drive to sleep. It's the speed of falling asleep. So it's fine to have physiological sleepiness, but we assess how strong that speed is in a clinical situation. Manifest sleepiness is when somebody else is complaining that you're sleepy. Unfortunately, in an online session, I can't assess how many are sleepy. You may be introspectively sleepy, but I cannot talk about manifest sleepiness. So patient will have behavioral signs of sleepiness, inability to remain awake, and in very severe situations may actually make mistakes. So how do you assess introspective sleepiness? Introspective is self-professed. Obviously, you use a lot of sleepiness scales which are mentioned here. So the questionnaires usually have a score, and based on the score, the sleepiness is classified. So the Epworth, Stanford, and PSQI are subjective situational assessment. Certain activities of daily living are mentioned, and the patient is asked what's the propensity for falling asleep. It's applicable for all sleep disorders. Specifically for OSA, these are semi-objective because it involves some anthropometry as well. Stop bang and Berlin questionnaire are used. So this is a snapshot of the Epworth sleepiness scale where you can score a maximum of 24, which means you're extremely sleepy, but a cutoff of 9 or above is enough to call yourself sleepy. The stop bang questionnaire is used in a...
1 second, there were some in the chat box. Yes. Some comments that sound is not optimal.
Can you hear?
Qualities.
Yeah, can someone type? Can you hear me?
The sound quality is not that optimal.
There are 2 of them saying it's not optimal.
Is it the mouse?
Okay, somebody says can hear, but sound is not clear.
Can you remove the mask?
Yeah.
Even sit there.
Is it better now? Seems muffled. No, I think it's audio output problem. It's better now? Okay.
Yes.
Yeah. So you want me to go over certain things quickly, or can I go proceed?
No, it's okay.
It's okay? Yeah.
Yes.
So I was talking about how to evaluate sleepiness, and just the previous one I go through. So questionnaires used to assess sleepiness like the ESS, Stanford, or PSQI are subjective assessments. And things like the stop bang and Berlin questionnaire are semi-objective assessments where some clinical assessment and some self-professed features are also assessed. That's a snapshot of the Epworth sleepiness scale where a score of 9 or above indicates that you're sleepy. The stop bang questionnaire was used in perioperative situations but is now also being used in the clinic to screen for sleep apnea. And yeah, high risk for OSA is yes to 3 or more items. All these are available in the public domain, so I'm not going through them in big detail. Berlin questionnaire is rather complicated. It again risk stratifies the OSA patients with suspected OSA. So this was all subjective assessment. Physiologic sleepiness or drive to sleep. How is that assessed? That's assessed with a multiple sleep latency test, where multiple sleep opportunities are given through the day. And we look at the propensity to fall asleep. How long is a person taking to go to sleep? And are they having any REM episodes, especially for narcolepsy? Pupillary size or pupillography, size study can also help in assessment. And ambulatory EEG or wearable bands are now available, which can again look for physiological sleepiness. Like I told you, it's a subjective assessment of the propensity to fall asleep. Assessment tools for manifest sleepiness are the maintenance of wakefulness test, vigilance tests like the psychomotor vigilance test and the Osler, and postural balance testing. I won't go into details. These are very important in critical professions like drivers and pilots, where you are diagnosed a sleep disorder and you have to certify them fit to go back to work. So all these tests are performed after treating the sleep disorder. What are the takeaways for the patient? I see certain messages in the chat box that you want certain aspects repeated. Since the sound clarity was not very good at the end of the presentation, I'll quickly run through the slides so that people who have missed can actually have a look at them. I'm not going to repeat in the interest of time. Okay, so takeaways for the patient. What do you give a patient after seeing them? You can give them a sleep hygiene leaflet where you ask them to establish a bedtime and waking time. Do not exceed 45 minutes of daytime sleep. Avoid excessive alcohol ingestion and smoking, caffeine, spicy or sugary food before bedtime, regular exercise, comfortable inviting bedding, and a comfortable temperature setting to keep the room well ventilated, and block out all distracting noise. Again, this is available in the public domain. If you go to the sleep education website of the ASM or the World Sleep Society's website, you get the sleep hygiene leaflet, which is free for public use. You can actually hand it over to your patients. You can also give them a sleep diary when you cannot figure out what the problem is. Sometimes in the first visit, like in a psychiatric disorder, we can't figure out what's going on, especially those with insomnia or inadequate sleep. We can give them a diary where they log their sleep on the following day for the previous night's sleep. When do we initiate further workup? When patient is excessively sleepy, when they have intrusive or loud snoring, they have insomnia, which is chronic, abnormal behaviors in sleep, and shift workers with multiple somatic problems. Also in obese patients with unexplained cor pulmonale, difficult weaning, or those who have to be assessed for intrusive snoring preoperatively, we can initiate further workup. What are the next steps? You have a sleep lab, cartoon of a sleep lab here, where everybody is sleeping. We don't want them sleeping on the chair. We want them in the lab when we are recording to see why they are sleeping. One may be sleep deprived, one may be obese and snoring, the third one may be insomnia, and you have a doctor who's sleeping who probably has come out of a shift. The person standing and sleeping may be having a sleep attack. Okay, so a sleep lab, when do you get the patient into a sleep lab and allow them to sleep on the bed, not in the waiting room, is what we'll be discussing. So if you look at these two cartoons here, this is the physician's dream lab, where I have a lot of monitoring equipments. I have a nice cozy bed, a soundproofed room with no disturbances. But the reality is what actually happens. We all fall asleep to certain background noises. We have our pets, the messy bedroom. So you have to remember that in a sleep lab, sleep may not be the best possible sleep, but yet certain events when they are uncontrolled can still be picked up, and most of the times we do in hospital. Obviously, I cannot replicate all this in a sleep lab, but the best I can do is to provide a comfortable sleeping environment and hope the patient sleeps. So when you look at polysomnography, it evolved from reams of paper where you can see this doctor is actually reading through epochs of sleep study, which has been printed out on a dot matrix printer, to a digital recording where every epoch is visible on the computer screen, and you just read off the pattern and score sleep and look for events. When can you do where can you do polysomnography? We can do in a sleep lab, and with miniaturization of devices, availability of cloud-based and Bluetooth wireless technology, we can do it in a home and monitor remotely as well. In a sense, what you do in a sleep lab is quite comprehensive, but the number of channels gets reduced. I won't go into details because other speakers would already have covered this. When do you do a polysomnography? Nocturnal or daytime? So you can do sleep studies in the daytime also, but that is more to monitor for propensity to fall asleep or when you want to do a vigilance testing. Nocturnal polysomnography is a gold standard to diagnose most sleep disorders, where you can do a full night sleep recording, a split night study where half the night is a CPAP titration, the first half is a diagnostic study, or you can hook on the polysomnography channels and do a CPAP titration study. Ambulatory monitoring can be done by an actigraph. Your so-called smartwatches and Fitbits are equipped with accelerometers. We do have dedicated actigraphs as well, which can ambulatory monitor sleep. So types of polysomnography, again, I won't go into details. A level 1 is a comprehensive polysomnography with all parameters. Level 2 is same parameters but performed at home and nobody is attending, nobody sees if things are popping off or whether data collection is okay. Level 3 has predominantly respiratory channels, and level 4 can be 1 or 2 channels which can just measure oxygen saturation. Again, I won't go into details because other speakers would have talked about this. So we're pictorially represented. A level 1 PSG, the patient is completely hooked up with EOG, ECG, and EEG and EMG for sleep staging. They have respiratory channels hooked up for identifying respiratory events, and they also have limb EMG for looking at periodic limb movements. In a level 3 PSG, you can see nothing on the head, so no sleep scoring is happening. This is adapted from ResMed. They have a nasal cannula and an oral thermistor. Only respiratory parameters are monitored with or without ECG in a level 3 PSG. Other modalities are also available, like an overnight oximetry. Can give this home to the patient, monitor for more than one night. Actigraphy, I already spoke about this. Longer monitoring is possible. And what are the indications? When will we actually do a sleep study? Sleep-related breathing disorders, restless leg syndrome, narcolepsy, and documenting parasomnias are hard and fast indications for doing a sleep study. Many times we do not have to do a study, especially insomnia. A sleep diary with an actigraph may be enough. We don't have to bring in a patient to the lab when there are a lot of sleep apnea patients waiting. The insomnia patient can wait for a couple of weeks till you have seen their sleep diary, you have seen their actigraphy data. Circadian rhythm disorders. Again, a thorough history, the circumstance in which the disorder happened, and a sleep diary with an actigraph may be enough. Sleep disruption due to poor sleep hygiene, you only have to educate the patient and reinforce education. Don't have to bring them into a sleep lab. Most parasomnias, like I told you, may not happen on the night of the sleep study. So unless you have to document a parasomnia for medical legal reasons, there is no indication to perform a sleep study. So why I am giving you this list is if you are running a sleep lab, you have to prioritize. Somebody with any of these disorders like sleep apnea, restless legs, narcolepsy, and a parasomnia, say a REM behavior disorder, who's probably committed murder. So these have to be prioritized over these disorders which can wait or maybe not even require a sleep study. So the summary of my talk is meticulous history taking and clinical evaluation are essential for evaluation of sleep-related complaints. Emphasizing good sleep hygiene is very important. Polysomnography is the gold standard but not necessary everywhere. Ambulatory monitoring devices can be used in selected patients. So thank you. I'll look into the chat window if there are any parts you want to see again. I can just project those slides so that you have not missed out on the flow. So somebody wanted the airway assessment, so I'll just put only that. So what I was talking about is how do you subjectively look at airway assessment. So this was the picture probably somebody missed. So all that you need to do is to look at the back of the throat with the mouth open, with or without the tongue protruded. If you can see all the structures, it means there's no crowding. If you can see only the soft palate, uvula and fauces visible, it's a grade class 2 airway. In a class 3 airway, you can only see base of the uvula. If you can see nothing, it's a very crowded airway. It is used for classifying the airway in a patient with a high risk of sleep apnea. somebody with class 3 and class 4 palate will have a high risk of sleep apnea. So if there are no more doubts, I will, okay, there is one more question here. Behavioral change aiming to improve sleep hygiene in individuals. Okay, so most of the times what we find in this question is from Maria. Okay, so when we talk of sleep hygiene, like I told you earlier, sleep was a subconscious process probably 2-3 centuries ago. With Thomas Alva Edison's invention of the electric bulb and the 24/7 lifestyle, with us devices, our smartphones and laptops and tablets, most of us are not following the winding down routine. We are not switching off and going to sleep on time. So in the absence of a sleep disorder, for most of us, it's the work schedule or our behaviors around sleep time that are causing sleep disruption. So like I mentioned earlier, you have to educate the patient that they have to relearn how to sleep. It's a natural process. You should go and sleep when you start feeling sleepy. And for you to feel sleepy, you should have the right environment. Dim lights, stomach not very full, not going to sleep immediately after having food, no gadgets or TV for at least an hour before bedtime, no caffeine of any kind, including Coca-Cola and stuff like that, for at least 6 to 8 hours before bedtime, and winding down routines where they read a book or listen to music rather than watch a movie or watch the news or something sensational, which kickstarts the brain. So these are the main things you have to tell the patient and reinforce the same. Also, you have to encourage, you have to tell them about intrinsic sleep need. There are people who don't require the 7 to 8 hours, so they need not actually stick to a number and say my sleep is not enough. But winding down routines are very important. For those who find it difficult to fall asleep despite all this, we can actually suggest certain calming routines like meditation, listening to alpha music, and also a warm shower just before going to bed. I think there are no more questions. Okay, I'll just put one more message. Okay. Thank you.